Hi, everyone, and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today we have invited Dee LeBeau-Hein to speak on clinical evaluation treatment planning. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall confidence in treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions of topics or speakers, so feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. I should note that for January of 2016, we are going to have our behavioral health webinar on the 2nd January, that is January 13th, due to the fact that the first week is people may not be back from holidays and that kind of thing, so we push that one back a week. Our center is a NADAC certified educational provider, and CEHs are available upon request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and we'll also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Dee LeBeau-Hein. Dee is a member of the Minikuju Band of the Cheyenne River Sioux Tribe in Eagle Butte, South Dakota. She has recently worked as a mentor in the Tioshbaye in engineering program at the South Dakota School of Mines and Technology and served as the president of the board of directors for the Sacred Heart Center, where she oversaw women's shelter and an adolescent program. Dee, thank you so much for joining us, and I will pass things over to you at this time.
Okay, good morning. Can you hear me okay?
Yep. Oh, yep,
Okay.
sounds good. Thanks, Dee.
Okay. Good morning and good afternoon for those of you that are in different time zones. Today we're going to look at clinical evaluation treatment planning. Here are some of the goals and objectives that we're going to be reviewing. First of all, you need to learn how to define what a treatment plan is. I'm making the assumption that I'm addressing counselor trainees, maybe doing some review for some counselor, CD counselor ones, and if there's any clinical staff on the call, this is a great overview to help with training purposes as well. Understanding the correlation between assessments and treatment plans is really, really important, and we'll go through that specifically. Overview of the treatment plan process, treatment plan histories, and then we'll introduce the treatment planning MATRS model, and then look at how to do progress notes. So let's take a look at what is a treatment plan. A treatment plan is developed between the client and the counselor with specific goals identified and strategies for interventions to reach those goals. I would say most treatment plans are client-based for for the sake of achieving those goals, you really want to work closely with your client. Most treatment agencies have their own assigned screening tools that they use. Results from an ASI is an instrument that's used to, it's an index scoring tool that's used to indicate where a client may be at presenting with their symptoms and such. You can also gather information from an actual clinical interview. Another source that some use are collateral information. And this is really a big source of good information. If your client is being referred from a different agency through the legal system or through housing authority or through their employment, then you're going to want to get a release of information and discuss some of those concerns that those entities may have regarding your client. So it's good to get some of that collateral information. Presenting problems, what is the client coming in being referred into your program for? So bridging the assessment and treatment plan is really important because you're going to be able to identify and prioritize what areas you really want to work on with the client. So when you receive the information and you're able to interpret, what your assessment is saying, you're going to begin to identify the areas that you're going to work with the client. I don't know of any client that ever skipped into my office and was happy to be there and sat down and told me the God's honest truth about their alcohol or drug use. So don't expect that perfect client to come through your door. You're going to have to probably dig for some of that information. And like I said, you're going to have to rely on other resources to get as much information as you can from them. The hope is that they'll be as honest as possible with their assessments. And some are, they'll do the best, they'll answer it the best they can. And sometimes they don't realize the extent of their use, so they may not answer some of those questions the way we would hope they would. So it's just really important to have that good communication with them when you're starting the assessment process. So it's important to evaluate your client's motivation to address their substance abuse. What brought them there? How do they feel about that? I recall having a client coming in that she blamed her babysitter for leaving her kids alone when she was out using. She said it wasn't her fault. She had a reliable babysitter when in actuality she didn't. So her reality was a little skewed on how she was being irresponsible. So it's those kinds of things that you want to, really be mindful of when you're talking to your clients, and not blaming or judging, but just addressing some of the how their life is unmanageable as a result of their alcohol or drug use. So it's identifying treatment goals and targeting behaviors. So this is all going to be developed through your interview with them. So at a minimum, the treatment plan addresses the identified substance use disorders as well as issues related to treatment progress, including relationships with family and significant others, employment, and those kinds of things. And like I said, a lot of times clients will come in not realizing how it's impacting other areas of their life. They think they have it under control, or it's no big deal, or you might hear some of those kinds of things. But when you look in other areas, like they're there for legal reasons or because of employment reasons, they kind of start realizing there might be a problem, but may not admit to it. So it's important to, once you receive the information and be able to interpret it, there's a stage model that Prochaska and De Clemente developed. And this is really important to use to look at where the client is presenting into your program. Are they coming in willing to work? Do you have to encourage them and kind of fight? Did they come in kicking and screaming? And did you have to pry their fingers off the front door to get them into your office, or just kind of get an idea where they're at with their treatment motivation? I mean, this is really, really important. So it's really important to see the impact that the client and family systems have on treatment decisions and outcomes. For the involvement to see what kind of progress or what kind of goals that are really going to be achievable. at the stage that when you start developing that treatment plan. So you're going to want to explain the assessment findings to your client and significant others involved in potential treatment. And this is really important that you're effective in how you're relating that information. A lot of times as counselors, clinical staffing, we might have our own dialogue and our own definitions or understandings of certain diagnoses, axes that we work with and things like that. And clients aren't going to understand that language, so it's really important that we break it down in real simple terms for them to understand. Confidentiality regulations, it's really important that they understand that you are obligated by law to adhere to privacy policy within your agency and federal policy through HIPAA compliance and things like that. But they also need to understand that if they disclose any information of seeking to hurt themselves or hurt another person or any kind of sexual abuse of a child, you are obligated by law to report that kind of information. So it's important that they understand that up front, but to really ensure and reassure them that their privacy beyond that is between you and them, and if it's between your treatment team. So the factors affecting the client's comprehension of assessment findings, it's important to be mindful of their mental well-being. If you're working with somebody that might have a mental disorder or that might be coming in with presenting with recent binging, and they may not be cognitively in a position to understand what you're talking about to them, you want to be mindful of those kinds of things when you're addressing the assessment results, so that they understand. And it sometimes might be helpful to revisit this part of your treatment planning, as you're working with your client, and you know that the clouds are kind of clearing and they're not as foggy mentally, and you can work and they can understand better what you're doing and the intention of your help. So roles and expectations of others potentially involved in treatment. So I worked at a residential treatment program, and I would make sure my clients understood that our residential staff, their roles and responsibilities after I left for the day. I would explain to the staff what if they had an assignment they were working on that evening, or there was something to be mindful of if something came up that was very sensitive during group. I made sure that the staff, residential staff, were aware of those things. So it's these kinds of things that you want to reassure your client that they're safe and they're in good hands, and you're all working together for their general well-being and their healing and recovery. So you want to provide the client and significant other with clarification and further information needed. Again, effective communication styles. I had a client in my program that was a fluent Lakota speaker, and she had a hard time understanding translating from Lakota to English or English to Lakota. It slowed her down in understanding. So so when I presented her with any kind of assignments, I was very mindful of that. So I would oftentimes sit and talk with her, and she understood that better than handing her a packet to write out and to answer those questions, because she couldn't formulate what it was exactly they were asking for. So it's things like that. You want to be mindful where your client's at in terms of understanding what kind of communication styles really work for them. And this again is really going to be dependent on how well you know your clients, what kind of information you gather in terms of history of treatment programs, or with employment, if they've had any kind of issues there with learning disabilities, or things like that. So you just want to be mindful of that kind of stuff. And you want to examine the treatment implications in collaboration with the client and their significant other. So you want to be able to explain perhaps some of the treatment models that your treatment program works with. If you're a client-centered treatment program, you want to kind of explain what that means and how you're going to be approaching their treatment and care. And then you're going to want to be mindful of the effectiveness of the various treatment models based on current research to ensure them that these have been scientifically tested and proved to work. If you're using evidence-based practices in your program, and also be mindful of explaining the client placement criteria, why they're in maybe intensive outpatient as opposed to inpatient, or why they're in outpatient as opposed to intensive outpatient. So you want to explain, the assessment details, the screening details, and why they were placed in certain areas, and what the cost issues. If there's a cost issue involved, you want to go through that with them, so they're clearly on board and understanding of what you're doing and why you're doing what you're doing. Again, you want to confirm the readiness of the client during the treatment process, motivational process, stages of changes. If you're not familiar with this model, I strongly suggest that you research this particular model, because it is something that you will be working with. And in your progress notes, you'll probably be addressing certain stages of this model as you're working with your client and moving them through the treatment process. You want to prioritize, again, once you're working with your client and identifying what areas of need they are coming in presenting with, you want to be able to identify those needs with the client. So treatment sequencing and the continuum of care, hierarchy of needs, interrelationships among client needs and problems. If a client's coming in presenting with alcohol issues and marijuana, cannabis, you want to kind of identify, what is their drug of choice, and then kind of get behind each one of those particular uses, and identify why they're, well, I'm really angry, if I smoke a joint I feel better. Sometimes you hear that. Or I just wanted to chill out after work, and I went out for a couple beers and I wound up drinking for a week, things like that. So when you're interviewing your client, you're going to really get a better idea of where they're at with their alcohol or drug use, and you're going to get a better idea of why they're using, and they may not see it that way, but this is, as a clinician, this is going to be your responsibility to help them identify some of those core issues. So when you're formulating mutual agreed upon and measurable treatment outcomes and statements, you really want to look at that client's motivation at that level. So when they're coming in, I had a client one time come in and she was very angry. She didn't believe she needed to be there. She didn't have a problem, and it was everybody's fault but her own. And I was okay with that. We sat and we talked, and I just encouraged her to stay, and let's give it some time, and blah blah blah. So in about a week through, she was willing, and her motivation changed after she realized why she was there, what we were working on, and seeing the other clients doing their work she was connecting with. Her motivation changed as she was progressing through the treatment process. So you're going to see that, and you need to be mindful of that and the different levels of client motivation. I rarely had clients kicking and screaming for the duration of the treatment program time frame. Majority of them came into compliance and worked their program and did fairly well. Treatment needs of diverse populations. You really need to be mindful of your different populations you're working with. If you have somebody in our situation, we're from the Sioux Nation, so we have clients that come from different reservations, and we're mindful of the cultural relevance of some of the treatment approaches. Some respond better to traditional healing practices as opposed to contemporary healing practices or Western society practices such as AA. One would rather go to a talking circle. So being mindful of those kind of treatment needs for diverse populations, it's really important as a clinician that you understand that diverse population culture and approach to our language and those kinds of things. And then being able to write that in a measurable outcome statement that's understandable to the client, so they see what you're looking for outcome measures. And then identifying appropriate strategies. So when we look at clients that, say, I had a client that presented with anger issues, And we talked about, what the intervention strategies we're going to do, anger management. We were going to look at, what were some of her hot triggers, red flags and things like that, so you kind of explain what the strategy is in presenting to the client what you're going to be working with, so they understand why you're looking for it. It's much like a doctor, they want to know your symptoms. They want to know when these symptoms present themselves. They want to know how long these symptoms have lasted and those kinds of things. As clinicians, we're doing basically the same things, but in terms of behavioral health and mental health. So when you identify those intervention strategies, you want to make sure that your client really understands what you're going to be using to work with them. And again, the level of clients' interest in making specific changes. I've had clients that have told me they don't want to work on certain issues, like with grief. I don't want to talk about it. I don't even want to go there. When a client says that, you don't want to force them into that corner, because they're telling you straight up they don't want to talk about it. So if they're willing to talk about their anger issues, and you can begin working on that, the hope is that they realize a lot of the anger has to do with the grief issues. And if you're working well with your client in the treatment staff, it's all on deck with your client. It's not uncommon to have your client come around and be willing to work on those grief issues, as they see that it's interrelated. So it's those kinds of things that you want to be really mindful of while you're working with your client. So again, treatment issues with diverse populations, you want to look at what intervention strategies you might have with that. And then coordinating treatment activities and community resources. If you're working in an outpatient setting and your client's leaving the program after the day's session, you want to be mindful of what resources are out there for them to attend meetings or talking circles or traditional ceremonies, or anything supportive to their sobriety and their recovery. What recovery resources, support systems are out there? So you want to coordinate that treatment activity and resource with prioritized client needs in a manner consistent with the client's diagnosis and existing placement criteria. And again, it's between you and the client and their significant other. If you're recommending the family go to Al-Anon and the client go to AA, you're keeping track of those kinds of things and explaining why that's important for the family to understand their loved one's addiction and the behaviors that are involved and those kinds of things. So you're communicating that with the family. Treatment modalities and community resources. Again, a client might not understand the purpose of a AA group, AA meeting. Some clients I know that have gone there and thought that it was a group session, and they thought it was supposed to be therapeutic for them. So they come back and said they didn't get nothing out of the AA meeting. So I would explain to them, that's a support system. It's not meant to be therapeutic for them. When they come to treatment and we're in group with a licensed, credentialed counselor, that's where they'll get the therapeutic interventions, and we will work with them accordingly. But an AA meeting is more for support purposes, to help support them in their recovery efforts. So once they understand that difference, they're able to see, the difference in approaches to their recovery, and they get a better understanding of some of those treatment modalities that we use and that aren't being used, or those kinds of things. Contributions of other professionals. You're looking at when you're doing referrals, maybe you might have them go to financial management classes, because they're in a lot of debt due to their use, and things like that. So you want to just kind of explain what those reasons why you're referring them to those kinds of areas, for their work, to help them with their stress level or something like that. And then again, it's important to understand your client's racial or ethnic culture, their age, the developmental level, gender, and life circumstances, and coordinating those resources to meet your client needs. And again, you're going to get a lot of this information through your assessments and through your screening tools that you're going to be using. So when you develop with the client a mutually acceptable plan of action and a method for monitoring, evaluating those, the relationship among problem statements, desired outcomes, and treatment strategies, your client is going to be a lot more at ease of what they're there for. and what they can expect from you and your treatment program. You're looking at short-term and long-term treatment planning. They understand what that means, short-term, and oftentimes I would explain to my client, that would come in for residential, you're here for 45 days, and then we're gonna keep you for an extra, maybe 6 weeks, just to make sure that we get you set up to reacclimate yourself back into the community, and then you're going to be participating in aftercare, for another 6 to 9 months, or whatever you agree with your client. They understand the process in that treatment planning, and why you're suggesting that way. And you might want to back it up with statistical information. It's proven that if you step down your treatment phases, it's a lot more helpful. So if they go from intensive outpatient to outpatient, and then out to aftercare, you're going to see probably a higher rate of success in their recovery that way. So just, understanding that process and explaining that to them and reassuring them there that you're going to be with them, through the whole duration of their recovery and things like that. And what methodology are you using for evaluation? So each agency has their own methods of how they're evaluating their clients and those things. So you understanding that process. If you're at a treatment agency that you're working with and you don't understand why they're using what they're using, but you're just using it because that's what you learned, it's really important to get behind it and figure out and understand why, so you can explain that to your client and they can have a better understanding, and you as a clinician can deliver it in a lot more confident manner. So you're going to want to inform, again, your client of the confidentiality rights. You really need to be mindful of your federal regulations. State regulations vary from state to state. Agency confidentiality regulations. Living in a small community, we would oftentimes have clients come in that were related to another client, or maybe related to a staff member. So we had our agency confidentiality regulations policies in place for that. And we handled it accordingly. Oftentimes a counselor would be pulled from group if that client was in that group, or they were assigned to somebody that wasn't connected to the family of that client, things like that. So it's just being mindful of those kinds of confidentiality regulations, and again, reassuring the client that your utmost priority is there protecting their privacy, so that you can build that rapport and have that trust with that client, and you can work together in helping them in their recovery. And what resources for legal consultation? You might have clients coming in with legal issues and may need to address those while they're in treatment. So you have those resources available on staff, or via community resources, or however you work those. But and then again, being able to communicate that in a manner that your client understands what is available. And this is something that I often did, and it's important to do, to reassess the treatment plan at regular intervals, and or when indicated by changing circumstances. There's a screening tool that I use, SASI, and I don't know if any of you are using that, but that was initially designed to use through the duration of their treatment. So you use it when they first come in, and maybe about 3-4 weeks in, you might reassess them with the SASI tool, and then at the end to see if they're progressing or how well they received the information and responded to the treatment therapy there at your treatment program. So you can reevaluate the stages of the treatment and recovery, and sometimes you might want to modify or change the treatment plan accordingly. So you'll look and sit down with them and say, well, let's take a look at where we're at with the treatment plan right now. You're getting close to discharging. We want to revise and see if you feel like we've met this goal of addressing your grief issue or addressing your anger issues or what have you, and you'll discuss that in individual sessions, or whenever you do your progress notes, you're going to be mindful of those kinds of things and share that with your client. So treatment plans are not meaningless and time consuming. or are ignored, or same plan, different names. I was at a program one time that one size fit all, and that just caused more problems than it did help the client. So it's really important as a treatment plan to be very specific in how you're designing that for the client's use. Um, Information requirements of funding entities, managed care, you want to be mindful of that. Is there duplication of information collected? Is technology used effectively? Paperwork is useful. You all have a lot of pile of paperwork to do. There's always a lot of writing after you do groups, or after you do individual sessions, or after you do clinical staffing, or whatever it is you're doing. You have to have a paper trail to back up your work. So that's really important. So is the paperwork useful in treatment planning, in the treatment planning process? Those are things that you really want to be mindful of when you're developing a treatment plan. So field of substance abuse treatment early work, it used to be program driven plans. So a program would say, we're going to go in and we're going to present a Rogerian therapeutic approach, and and this is how we're going to do it, and then they would design all the treatment plans that way. Well, that wasn't always the best approach, and it turned out it wasn't as helpful as they thought it would be. So client needs are not important as a client is fit into the standard treatment program. Plans often include only standard program components. So they'll do group, they'll do individual sessions, and so they have really specific things. But that's kind of what when you talk about program-driven plans, this is kind of what you're going to see. There's a little difference among clients' treatment plans. So it's if two clients were talking together, they're like, oh, I have to do the same thing. Well, yeah, me too. You're probably looking at a program-driven plan if the clients are kind of seeing a similarity there. You might see a program-driven plan that says you have to attend 3 AA meetings a week. You're going to complete steps 1, 2, and 3, and you're going to attend 3 week. So you're going to see all these things in a program-driven plan. And this might be work for your program, and they might have success stories from that. But a lot of times, this doesn't always fit all the clients that come in through your door. So often, program-driven plans include only these services immediately available in their agency. They do not include referrals to community services, parenting classes, financial management, or you won't see any of that in a program-driven plan typically. But as time went on and treatment approaches were being looked at, and the recidivism rate was looked at, and were clients returning to treatment? Why are they returning? What was going wrong? What could we have done differently? There was a shift. And once they realized that if you individualize a treatment plan and you can offer other options that fit the client's personality, their lifestyle, who they are and how they are, that's more personalized, you're going to have a little bit more success, probably a lot more success. So individualized plans, they're sized to match client problems and needs. So if I was working, like I had my client that wasn't able to handle working packets, like here's a first step packet. She couldn't do it sitting down effectively. She wouldn't do a very good job sitting down, reading and writing and comprehending something like that. So I had to make adjustments to her treatment approach and her treatment plan and how we were going to work on those steps 1 or steps 2 or 3 or whatever we were working on. I didn't use what was standardized in the treatment agency that I worked with. I was able to modify that. And some of your programs you may not have that ability to do, but if you do, it's really important to try to individualize those plans and customize them as best you can to fit the client's needs. So to individualize a plan, the information that you're going to need is, what does a counselor need to discuss before developing a treatment plan? So when you're gathering your assessment information, information for your assessment, your screening tools, your collateral information. It's those kinds of things that you're going to want to look at. What does a counselor need to discuss before developing a plan so you can do a more specific plan with the client? And where do you get the information, the guidelines, the tools used, and those kinds of things? And if you're not familiar with some of this, talk to your clinical supervisor. They should have access to this and be able to reference and guide you to the areas that you need to use. Possible sources of information. Here again, this is some of your collateral information. Probation reports. I worked with a number of clients that were on probation, on parole. So I work closely with their parole officers. So oftentimes I would have to generate a weekly progress report for them, or we would have calls and we would discuss some of the things that we were working on, or and it was what basic information I was sharing. Wasn't the specific work that I was doing with the client. It was more generalized because of the client's confidentiality and privacy. So if I had a session individually with the client and they disclosed some very traumatic domestic violence experiences in their childhood, and they got very detailed with me, I didn't share that with the probation officer. I would just say that we discussed some domestic violence issues, and the client is working on, coming to agree on working on some of those issues or something like that. But I never divulged any specific information. So you really need to be mindful of that as you're gathering information from these entities, or if you're sharing information with any other entity, you want to be mindful of the client's confidentiality issues and the federal laws that are protecting not only the client but your agency, that you don't have to share some of that information in the manner that they may think that you should. So other sources are, your screening results, being able to understand your screening tools. It's important to understand what you're using, why you're using it, how to read it, how to interpret it, what it was designed for. So you have a better understanding when you're approaching your client to use this tool, and you'll know which tools to use if your client's presenting with depression. There's a specific tool out there for just that. There's tools out there just for opiate use, for just alcohol use. So, you'll be able to understand what sources to access for that. And your assessment scales, it's important to understand how to read your assessment scales and where a client fits. And if you're not sure, go to your clinical supervisor and explain to them, well, this is kind of where I think they might be, but I'm wondering if I shouldn't put them here, and discuss that. That's what clinical staffing is. So you can develop the best treatment plan that's going to be more appropriate for the client by doing that. So you have a really good understanding of why you're using those assessment scales. Collateral interviews. I often use this with their family. I would have clients coming in to say that, yeah, my family, yeah, they know I use, but they're okay with it. They don't give me a hard time. Well, and I ask, well, who do you live with? And well, my mom and my aunties and some of my cousins. I said, well, would you allow me to talk with them? Yeah, because they're going to tell you the same thing. I said, okay. So I would get a release of information signed, and I would contact them and visit with them, and they would say they're very concerned about the client, their loved one. They're very concerned, and they've talked to them repeatedly about stop using, and their concerns about not taking care of themselves and them getting hurt out there, but the client wouldn't pay attention to them. So you would hear something different than what the client may be telling you. So it's important that you utilize your collateral interviews, your resources, as effectively as possible, that you think that's really going to help in the process of developing that treatment plan. And then when you're returning that information to the client, you're not going to, come back and say, well, gee whiz, you said your aunt didn't care when all this time she was worried sick, and it's going to be important how you address that with your client in a manner that's in a compassionate, loving, supportive manner, so your client doesn't feel threatened or doesn't feel like they're being accused or things like that. So as a counselor, it's really important your communication style and how you repeat and share that information with your client. That's going to be supportive and encouraging and not judgmental and condescending or criticizing or anything like that that they feel like they're being attacked or pinpointed or threatened or anything. You got to be mindful of how you communicate that with them. Here is a biopsychosocial model. These are three areas that typically you're going to be looking at while they're in treatment with you. So these are areas that when you're developing a treatment plan, you might be looking at certain areas more so than another area. So you might want to look at, does the client have a car? The sociological aspect. Can they access a public transportation? If I say you're going to need to do, and they agree to it, say I think I can do 2 meetings a week. Do you have transportation? Is that realistic? Is that possible? Can you get there? Well, I could probably get my cousin to drive me on Mondays, but I don't know about Thursdays. No one's really around, or whatever. So you really want to take a look at the availability of the resources they have to get to some of their meetings that you might require them to do. And then, take a look at how available are drugs or alcohol in the home. Is there anybody else in the home that's using? And if so, is that really a safe place for them to be around? And if not, is there an alternative for them? You might want to open that discussion up with your client. And how close do they live to the treatment center? They're doing outpatient. How long does it take them to get there? If there's a snowstorm, is that going to create a problem for them to make it to class? Do they have money to put in for gas if they have to have somebody drive them? I mean, those kinds of things that you want to discuss with your client to see what's feasible, what they can accommodate and what they can't, and be realistic. And if it's okay that some can't make it, maybe you have some sort of teleconferencing that you guys can do, Skyping and hold a session that way if it came down to it. I don't know, but they're getting into virtual counseling now, so it's online. Here's another area, the ASI Problem Domains. Look at some of the biopsychosocial model. Uh, so like medical status, you're going to look at if they're diabetic, if they have high blood pressure, if they have certain health issues that you want to be mindful of while they're in treatment, if that's realistic for them to work on some of those things. Maybe somebody's dealing with obesity and they need to be on a diet, and is that something that can be addressed in the process of their treatment? Psychiatric status, we had in our facility, we had a standard referral for a psychological evaluation for all our clients that came in, just so we could to see where they were at with their mental well-being. And a lot of times our clients would complain like, oh, you're calling me crazy, or you think I'm crazy, or you think I'm nuts. And it's like, well, no, we don't. But this is just part of our process and evaluation. We just want to make sure we cover all our bases, and we want to make sure that we provide the best care to you while you're here with us. And if there's anything there that that needs to be addressed, we're going to help you get those needs met. Or one of the other programs I worked with was a holistic treatment approach, where we worked with their physical, mental, spiritual, well-being, and we would explain that to them that this is all part of our treatment process. We work with this to help you in all these areas. So it depends on your treatment agency and what you all provide, and if that's something, a standard evaluation that you do, and you're going to want to take a look at that. Family and social status, what's the relationship with the family? Um, are you comfortable being in a group? Would you be comfortable going into a AA meeting? I know an individual that's not comfortable in group settings and felt they would not do well in a AA meeting. Um, and So we looked at alternative ways of support through a support system with them on that. So, this is part of your job as a counselor in assessing and finding ways to work with your client. You might have to get a little creative. So it's going to be really important that you have your community resources and your treatment program resources available so you know what you can and can't do to help meet those needs of your client. So why make the effort? Why do you want to individualize treatment plans? It leads to increased retention rates, which are shown to lead to improved outcomes. And that's something I mentioned earlier with the recidivism rates. We don't really want to see our clients return to treatment, but oftentimes, that's not uncommon to see them return to treatment. I really stress with my clients that would return to treatment, like, oh my God, I'm back here again. I'm back here again. This is embarrassing, or I feel so ashamed, or, those kinds of things. And I would try to find, the positive, while you're back in a safe place. Two, the last time you relapsed, it was 2 weeks after you left treatment. We're 2 months into your recovery and you relapsed. So something stuck, something worked for you. So, it's not as bad as you think it is, so, try to find those points that are encouraging and supportive to them, if they do return to treatment. You know, well, we didn't work it out this time, but well, this time let's readjust and tweak a few things in the treatment plan so we can, address maybe your anger issues a little bit more, or whatever it was that you were working on. And it empowers the counselor and the client relationship and focuses counseling sessions. So you have a better understanding of what it is you're going to be working on with that client when you individualize those plans. Um, it's a lot more specific. And, if I go see a doctor and he tells me that I have to go to swim for, put 10 hours of swimming in a week because it's going to help my agility in walking or something. I want to know if I don't do 10 hours, what's going to happen. So it's you kind of have to explain things like that to clients. You got to be real specific about how this is going to lead to their recovery, by making these lifestyle changes or making these cognitive changes, in their understanding and reasoning of why they do what they do. Because as you all know, we all don't wake up one day and say, "Oh, I want to live my life and be an addict. That's what I want to do for the rest of my life." That's not realistic. For most healthy, normal people, that's not what they want to be or do. So there's a reason why they're using the way they're using, and it's your job to find out what that is. So why make the effort? Individual treatment plans, it fits the client well. And they'll let you know. Clients will tell you. If you have that connection with them and you're on point with them, they will tell you, "I think I can do this. This sounds like something I can do." I mean, those are statements you may hear from your client. Or, "Gee, I'm glad I'm here. Now I understand why you were saying, to do it this way," or "Now it makes sense to me, why I used the way I did," or things like that. As a person in recovery, I've got 27 years in recovery, and I remember when I went to treatment, um, I didn't understand why I couldn't stop at one beer, or why I couldn't stop at one pill, or I had to do the extreme. So when I went to treatment and they explained to me the addictive quality or the addictive nature or personality of addicts and the mentality and all that goes with it, it made sense to me. And so that helped in my recovery. Um, Once I got to my core issues and I was able to better understand why I used the way I did, and get into my feelings and being able to express those feelings, and understand why we had the certain goals that we did in my treatment plan. It all fit. It made sense. So this is kind of what you're going to be looking at when you're working with your client. So the ASI index, like measurements, the ASI are used to fit the client's services or their needs. And if you're not familiar with that index, I strongly encourage you to look that up and familiarize yourself with it, because it is very helpful. So what is included in any treatment plan? These are some of the components, and we're going to go through some of these a little bit more specifically, but you're going to want to have a problem statement. And that's all the information that you're getting from your assessment. So the client's coming in presenting with drug or alcohol addiction, based on whatever their presenting problem is. You're gonna have an opening statement basically of what their problem is, and based on the assessment that you're bringing in. You might have a assessment tool that you're using online that automatically writes it for you in a narrative fashion. So what you put into that information, you're going to generate this problem statement. Goal statements are based on the problem statement. So if you identify clients presenting with anger issues or grief issues or shame issues or whatever it might be, you're going to be able to identify, they're going to be working on those specific issues while they're in treatment. And what is the objective? What the client will do, that's your objective. The client is willing to attend anger management classes. The client is willing to write a letter to their loved one that has passed. Whatever their client is willing to do, that's the objective. That's what you want to get to. And then what the staff will do is what the interventions are. The client will bring this assignment in, and we'll discuss the loss of their loved one and work through their grief issue by utilizing this model or however you're going to do it. That's what you're going to address, and those are what you're going to find in a treatment plan. So it's something that is all ties together. So it's important that what you collect up front is going to benefit each of these areas as you develop that treatment plan. So treatment plans, again, are based on gathering information during the assessment. Your goal statements are based on the problem statements and reasonably achievement in the active treatment phase. So it's really important that you identify a goal that is achievable, that's reasonable for the client. And then again, they're going to let you know if they can or they can't do that, and whether they have the time to do that. Keep it in mind that when you're working on discharge summaries and aftercare plans, this is an area that you might consider starting a goal and going to a point with it and saying, well, we can pick this up in aftercare if it's something that you really want to work on, you really want to address. It's something that we can continue as we're moving through the phases of your treatment, and they may agree to it that way. Objectives are what the client will do to meet these goals, and then the interventions are what the staff will do to assist the client in these goals. So other common terms you might hear: what are the action steps? What are measurable activities that the client will do or you as a staff will do? What are some of the treatment strategies? This is where you might be introducing some of the modalities that your treatment program are using, or as a counselor, what strategies you will be using, and some of those benchmarks and tasks. So these are some of the language that you might hear in your clinical staffing, or you might want to use this in some of your treatment planning. So again, when you're looking at your treatment plan components, you want to make sure you have all of these addressed. And again, if you're not sure if you're addressing these effectively, go to your clinical supervisor and go through it with them. But most agencies have a standard treatment plan template that they work with, and it's oftentimes set up already for you, and you just have to plug in the information. But if you're not sure, ask a colleague, a coworker, or clinical staff on board with you. Discharge plan components, client strengths are reflected. Here again, like I said, you're going to look at the phases that a client is going through the treatment plan process. You're going to want to identify what those strengths are, and every client has strengths. Every client has strengths. You're going to find those as you start working with them, and always acknowledge those strengths as you're working with the client. So you seem very resilient. You're very resilient when you were really hurt, and you were really seemed to be having a hard time yesterday. But I noticed today in group you seem like you're back on track, and you're focused, and you're ready to go. That's resiliency, and acknowledge that with the client. And that's really helpful for them to see their own strengths, because a lot of times clients come into treatment broken down. They don't see it. They don't realize that they have it. They think they're weak, and they don't have a lot of positive things going for them. So it's really important as a counselor to address that, reinforce it, and help the client see what their strengths are. Participants in planning are documented. So how they're involved in the planning of your treatment planning, your discharge plan, other people that are involved, you're going to make sure you have all that documented. The DENS treatment planning software includes these components. So if you want to look at something like that, or if you're utilizing that, familiarize yourself with that software. So considerations in writing, all problems identified are included regardless of available agency services. So if you identify that a client has maybe they have PTSD issues that they've identified through being in the military, or maybe a domestic violence situation, but that's not something that you feel confident or you're capable of addressing immediately while they're in treatment, you're going to still identify that in your treatment plan, but even if you're not able to address it immediately, so it's important to still put it out there. Don't say, well, because we can't address it, we don't want to list it. No, you want to have it out there. So include all problems, whether deferred or addressed immediately. Each domain should be reviewed. So you're going to want to make sure you look at each area that you're identifying in your treatment process, in the different phases that they're in, and you're going to want to answer, or you want to make sure you have those addressed accordingly. So a referral to outside resources is a valid approach to addressing a problem. So again, it's important to know your community resources. If you're not able to address it there, you might want to share with your client, say, we may not get to this here while you're with us, but if you're willing, through your aftercare, we can make the referral, and you can start working on that with them. And oftentimes your client will say, yeah, I'm willing to do that. So these are things that you need to be mindful and considerate of when you're writing the treatment plan. As I stated earlier, in writing problem statements, they need to be non-judgmental, and not to use any jargon statements like the client is in denial, like I gave the example of the client that, said, go ahead, call my aunt and my cousins. They don't think I have a problem. And, when in fact they did. You wouldn't put that in there. I contacted their Aunt Judy, and she said the client is in denial. You want to be careful on how you use those kinds of statements. Client is codependent based on your observation or somebody else's. Be careful how you use those kinds of statements. Use complete sentence structure as you're writing your treatment plan. And if you're not sure, pull a treatment plan of somebody there on staff that has successful treatment plans, and take a look at how they're writing it. You can also go into different manuals that show you how to write specifically some treatment plans, and we'll get into an example of that here shortly. So how we write an objective or intervention statement through MATRS. A MATRS model is based on the acronyms for measurable, something that's measurable, that a client and your staff are able to show the client that there is in fact progress in what you identified as a goal that you're working with. because when a client sees that, it helps them to see that what they're doing or what they've done worked. Something worked, and they're able to see. So like when I said a client came in 2 months of a relapse as opposed to 2 weeks, something there was different. There's something measurable there that worked for that client that you can identify. Well, what did you do different? Well, I actually went to meetings a lot more often than I needed to. That's measurable. You can write that, something like that. So you want to be mindful of that whatever you identify as an objective or intervention, that it is measurable, that the client can see on a continuum of care, that they're moving, progressing on that, or regressing. If they're not achieving it, you could show the client, well, you haven't been doing well in this area, and we need to take a look at what's going on with that. So it's those kinds of things, and it's got to be something that's attainable. Is it something that they can achieve while they're there? Is it something that is available within their area? Is it attainable? Is it something realistic? Can they in fact do this? Can because you don't set them up for failure. You have to identify things that are realistic. I know there is old school treatment planning, thinking of 90 meetings in 90 days. Some people still do that, and it may work for some people, and for some people it may not be realistic for them. And you have to be aware of that, so you're not setting the client up for failure. And time limited. You have to be able to set limits on the time that you're putting your client through their planning. What are the time limits? How are you going to measure that? And be specific. It's important that they understand that. So this is what matters, and this is the model, and this is how you use it in your treatment planning process. So some of the objectives and interventions for MATRS are measurable. Achievement is observable. Measurable indicators of client progress, assessment scales, scores. Like I said, some of your assessment tools you might use more than once. Besides the initial interview, you might use it through the duration of their treatment program or at the end. So you have that available. Client report, behavioral and mental status changes. So you're consulting with your, if you refer them for a psychological eval, you're consulting with them in terms of how well they're doing, where you're seeing changes, those kinds of things. Just a point I want to make: when you're doing psychological evals, as you all well know, if a person is coming through, and some programs only require their clients to be maybe 3 days sober, or 5 days sober, or whatever it might be, a week clean. Sometimes depending on the drug or depending on the extent of their alcohol use, they may present as depressed or with high anxiety. And then you send them for a psychic eval, and it may come out that they have anxiety issues, or they're clinically depressed, or something like that. You might want to re-evaluate them, about 2 to 4 weeks in, just to make sure that isn't misdiagnosed, or because for withdrawal symptoms, sometimes clients will present as depressed when they come off of the alcohol and they're in your treatment program, and you're like 3-4 weeks in, and they seem, the first 2 weeks they're depressed, and then 3-4 weeks in they start pepping up a little bit. You wanna make sure that you're understanding those mental status changes accordingly when you're clinically staffing your client with your psychological staff, if you have them on board, or whoever you might have referred them to. I hope that makes sense, but it's important to understand that component. Objectives and interventions are attainable during active treatment phases. So, you got to be able to understand what phase they're in and be able to identify where they're at in that process. Focus on improved functioning rather than cure, and because they're in recovery, as opposed to being recovered. It's a process, it's a lifestyle change, it's going to be for the rest of their life that they're going to be getting better and improving their functioning and becoming normal in terms of their thinking and their feeling and how they're responding, reacting to certain situations that would in the past maybe trigger use. They're being able to identify that feeling of frustration instead of coming out as anger. It was really frustration or something like that. So you're focusing on those improved functioning um, elements in their recovery process rather than the cure. So identify goals attainable in level of care provided. Revise goals when client moves from one level of care to another. So that's important that this is a process not only for the client but for the counselor as well, that you understand when they move from one level of care to another, that you're able to identify those and make those adjustments accordingly. Time limited, focus on time limited or short term goals and objectives. Like I mentioned before, short term, we usually look at within a year. Long term is anything outside of a year. Objectives and interventions can be reviewed within a specific time period. If you're a 45-day treatment program or a 28-day, you know what you can do within that time frame, and then after that, if they go to a different phase of treatment and care, what's the time frame that you're gonna set on that, and again, be realistic. Is that going to work for the client, and those kinds of things. So it's important to understand that aspect. Client can realistically complete objectives within a specific time. I just mentioned that. Goals and objectives are achievable given client environment, support, diagnosis, and level of functioning. Again, you want to make sure you're looking at their socio-economic position, their biosocial situation. Health-wise, are they able to handle certain things that you might identify in the treatment plan, and just things like that. Progress requires client effort, and you'll know if the client's going to try or not, and you'll know real soon. Objectives and interventions are specific and goal focused. So being specific about what it is that you're going to do and how you're going to address certain situations. Addressing specific behavioral terms, how level of function impairments will improve. So you want to be specific with them, and maybe even show them or connect them with somebody that they can actually visually see that it's working for them. Sponsorships, mentorships, peer recovery coaching, those kinds of things are helpful with helping a client see and different changes that are positive and that are realistic. So the MATRS test is, you got to ask yourself, is it measurable? Can change be documented? Is it attainable? Achievable within active treatment phase? And time limited, is time frame specified? Will staff be able to review within a specific period of time? Is it realistic? Is it reasonable to expect the client will be able to take steps on his or her behalf? Is it agreeable to client and staff? Will client understand what is expected and how program staff will assist? And ask them, do you understand? Ask them to repeat it to you if you think they don't understand. And again, clients usually will tell you straight up, I don't get it. I don't understand what you're telling me. And if you're having a hard time communicating that with your client, then get to your clinical supervisor and get help, because it's not good to confuse your client. If your client's confused, they're not gonna approach their treatment plan with as much confidence as you would like them to. So it's really important that you are able to communicate what it is you're going to do, how you're going to achieve it with your client in a manner that's going to be understandable. So the treatment planning process review, conducting the assessment, collect your client data and information through the resources that we addressed. You want to identify the problems. You want to prioritize the problems. Be realistic. What can you achieve within the amount of time that you have that access to this client? And if you're only able to achieve one or two things, that's okay. You start at something, your client's going to work on it. That's progress. And you can always do outpatient counseling. You can always refer for different services outside of your treatment planning. So with your prioritize those problems. If you can't address them there, you have the resources available that you can. Develop goals to address those problems and remember MATRS, objectives to meet those goals, and interventions to assist client in meeting those goals. So these are some of the things that you're going to want to see when you're documenting your progress notes. Okay, I pulled a file one time on a client, and because I knew that they had returned, so I pulled the file, and they were assigned to a different counselor, and the counselor put in there had an individual session. Period. That's all it said. Type of session, individual session. Level of care, nothing. Date, had the date, client name, had the counselor name and signature. So when it came time for me to work with the client, I didn't have any clue what they were working on. I didn't know if they were working on grief issues or, if they were working on shame issues. I didn't have any clue what they were working on. So it's important that you be a little bit more specific in your progress notes when you're writing and documenting. For if you're not there and another staff has to pull that file and pick up for you, they have as best information as you can give them so they can pick up and not start all over, because it's hard for clients, especially if you build a good rapport with them, to restart that whole process with somebody new. So if they know that as a staff that you guys are all on the same page and you're working together for that, for that client's well-being, it's easier for them to come and share with you if you have better understanding based on their progress notes. So some progress note formats you might see are NAPT, SO, the SOAP. I'm more familiar with SOAP than the other two, but you have whatever your treatment program uses as a format. You'll understand how to go through this through your orientation with your treatment program staff, and how to put those notes down. But I just want to reinforce the point of putting specific information to help your client or your staff in reading those progress notes. So the documentation basic guidelines, are there. Of course, you want to date it, you want to sign it. It has to be legible. The client name, unique identifiers. Some programs use specific coding to identify their clients for privacy, confidentiality issues. Start and stop time is important, especially if you're billing. And if oftentimes you hear hour sessions. Sometimes a client will need more time, and so you have that documented why you went over your allotted time, or why you started late, or whatever it might be. You really want to have those things identified, and the credentials, what your credentials are. Content of session and client response. So you might, like I'd mentioned, the client came in, admitted they were angry, and when I talked about grief, they didn't want to talk about grief. They were willing to talk about their anger, what got them upset, and why they were upset, and who upset them, and those kinds of things. But when I came to the grief aspect, they didn't even want to go there. So you want to identify that in your, the content of the session was, the client was unresponsive, was unwilling to discuss grief issues, or whatever it might be. You want to identify that. And progress towards goals and objectives, where, the client, in my case, was identified their grief issues during the course of our treatment. So there was progress towards that. And we went in and we talked about it in an individual session, and they agreed to work on that during outpatient. But at the time that they were there, we really did address a lot of their anger issues, and identifying those triggers, and looking at alternative ways to deal with that anger, that because they were very outward in their anger, sometimes very destructive with their anger. So we looked at ways of modifying that behavior and identifying what areas they needed work in. So that kind of thing, of being able to identify the progress towards those goals and objectives. Specific problems, goals, and objectives, if there was, again, like PTSD, or if there were specific areas in their health, maybe diabetes, specific problems there that they weren't on their medication or taking their medication while they were drinking, you want to be real specific about those kind of issues, that health issues, and where you're guiding them to in their treatment. Interventions used, you want to be very specific about how you're addressing those problems and the goals and objectives within the intervention process. Again, if you have specific modalities in your treatment program, understanding those so you can identify those goals and objectives. And any new problems or goals and objectives that might come up. It's not uncommon. I've had clients come in that were with their significant others, and as they started getting healthier, their significant others didn't want to be a part of their lives anymore because of whatever reasons, which created some new problems with relationship issues or status issues with their client. So you might want to start looking at something like that. Be mindful of those kinds of shifts and changes, or family changes and things like that. So that's something to be mindful in your documentation. Entry should include your professional assessment and a continued plan of action. So you always want to be able to identify around the curve. Kind of always keep in mind, you want to look around that curve and see what's possible or what's available for that client. So you want to have a continued plan of action. So if this client continues with the progress and with the treatment progress, they're going to make it to this stage, and you have something available for them. Describe your changes in your client status, responses to outcomes of interventions, observed behavior, and this not only isn't with just you as a counselor, but it could be your staff as well. Because other staff, if I don't know if you clinically staff your clients, but if you do, then this is stuff that usually comes up during that time. Your other colleagues or coworkers will identify, I seen your client and they were acting this way, because sometimes clients can be very manipulative and be very very well behaved in your presence, but not so much in somebody else's presence. So observe behavior. It's important to be mindful of that as well. Progress toward goals and completion of objectives. To summarize everything, the presentation, treatment planning, model 5, these are all the things that you're going to want to, that we just went over: obtaining and interpreting the information, explaining your assessment findings, providing the client significant other with clarification and further information is needed. Examine treatment implications in collaboration with the client. Confirm the readiness of the client. There's your motivational level. Prioritize client needs in the order that they will be addressed. And again, your client will help you with this if they're willing to or not. Again, be realistic. Be realistic with them. What's achievable and what's not. Formulate mutually agreed upon and measurable outcomes. Identify appropriate strategies for each outcome. Coordinate treatment activities and community resources with prioritized clients' needs. Develop with the client a mutually acceptable plan of action and method for monitoring progress. You want to inform client of confidentiality rights. Get releases of information. I would encourage you to get those right away up front as you identify the collateral information that you're going to be collecting. And if you're going to do any referral services, you're going to want to get those releases of information and be specific about what it is that you're going to be asking that entity for when you do the referral. So if it's for a psychological eval, you want to have the freedom to talk to the psychiatrist about the client's treatment progress and their progress maybe with them, and so you're coordinating services accordingly based on shared communication and information. Reassess the treatment plan on a regular interval or when indicated by changing circumstances. Like I said, I've had clients in treatment that have lost loved ones, that have passed away unexpectedly during treatment. So we would have to, and they weren't able to focus on certain areas, so we would have to go in and change some things and change time frames and things. So you're very mindful of how to go in and reassess and change treatment goals or objectives based on changing circumstances that might occur while they're in treatment. This is a book that I used, and I know a number of other colleagues have used. The ASAM criteria gives you looks at the different levels of care, and it identifies in different phases and gives you actual criteria of how if they meet certain criteria, what level of care they should typically be in. So if you don't have this manual, I would encourage you to get it, or to take a look at it, or talk to your clinical supervisor if that's something that you think you could utilize. And but most programs, I think, are using ASAM criteria based on insurance needs and things like that. But it's clinically driven, and it's not program driven. Criteria do not involve a prescribed length of stay, but promote a flexible continuum of care. And that's important to note, flexible continuum of care. It involves an interdisciplinary approach to care. It includes informed consents, so you can get an idea what you can ask for. It's also outcome driven, and it clarifies medical necessity. So in certain levels of care, here you have early intervention. Another level would be outpatient. Another level would be partial hospitalization, residential, inpatient, or medically monitored intensive. And ASAM will go through each one of these and have a variety of examples and information in there in each of these areas. So a dimension of ASAM, acute intoxication and withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use, or continued problem potential and recovery living environment. So the severity in each dimension can be rated as mild, moderate, or severe. And you as a clinician would identify where they would fall in that based on your assessment and your clinical interview with them using the ASAM criteria. So the early intervention is level 0.5. Early intervention is that level of care, one-on-one counseling and educational programs. Patient do not meet criteria for substance-related disorder, so problems in dimension 1, 2, or 3 are stable or being addressed, and it'll go through that with you and in a little bit more specific areas and how to read that. Your next level of care might be outpatient. They might fall into that area. So it gives you an example of some of the therapies that are included, individual and group counseling, and these are things you're going to share with your client. Family therapy, educational groups, psychotherapy, occupational or recreational therapy. So those are some examples of that. Outpatient treatment, no withdrawal, and here's the dimensions. Clients may meet 1, 2, or 3, or maybe just meet 1 or 3 or whatever. Again, you'll familiarize yourself with this, and it'll help you identify how to assess and recommend what level of care you're going to want to put the client in. And here's another example, dimension 4, willingness to comply with treatment, acknowledges substance use and wants help, or ambivalent about substance use, or doesn't recognize substance use. So you'll identify where that client falls based on your assessment. Able to achieve or maintain abstinence only with support. Supportive environment for treatment, inadequate support system, but willing to obtain a support system. I would tell my clients oftentimes when they come to treatment and they were allowed visitation, they had to tell me their relationship with the person that was visiting, and if they were somebody that they had used with, they weren't allowed to visit during the time they were in treatment, because I would start the support system building while they were in treatment. I told them once they left treatment, they could interact with whoever they wanted, but my hope was while they were in treatment that they would identify people that were supportive of their recovery, and then they could come and visit. So then they would tell me, well, my friend Susie would, was always supportive and always wanted me in recovery, and she would be a good person. So they would go on their visitation list and be allowed visits with her, and whatever. So that's something that we did to encourage that support system building. Family is supportive but needs intervention to improve chances of success. Sometimes families are still using, but they want to come and help their client, and that's going to be something between you and your client and how you want to support that or encourage that interaction. But hopefully there's family therapy involved, and families are getting involved in the recovery process as well. Level 2 is intensive outpatient, and the client will present with these typical areas. And you'll identify these as you move through abuse of family, diagnosed emotional, behavioral, cognitive disorders that requires monitoring. They need structure. They need to be in a structured environment to sustain their recovery. Systems deteriorating at a lower level of care. This might be somebody that started off with outpatient, or now they need intensive outpatient because they didn't do so well on the lower level of care. So you're moving them into this level of care based on their presenting needs and the lack of progress in the lower level of care. And that brings us to the end. We're going to open it up for questions and any discussions. That's a lot of information I threw at you in a short period of time, but I am very open to questions if it's something that I can answer now. If you have that available, I'd be happy to do what I can. If not, you can always email that to our host and they can get it to me, and I'd be glad to communicate that with you. So that's all I have.
Wonderful. Thank you so much, Dee. That was a wonderful overview. And yeah, like you said, it was a lot of information to take in. So yes, if you have questions, please type them into the Q&A pod right now. Looks like we do have a question already from Larry. In group treatment planning, is it acceptable to have a cookie cutter goal with a statement on how it will apply to the client?
It is okay to do that as long as you're very specific in your response. So if you're saying, yeah, when you say a cookie cutter goal, so I worked with enough groups that's not uncommon to see, but you just need to be very specific in how you write that progress note or your group note for that specific client individually.
Great, and yeah, we'll just take a few more minutes for questions if you have any other questions. While we're waiting, in case any more come in, I'll just remind everyone we will be sending an email out to everyone who attended, and even if you know people who registered but weren't able to attend, they'll be getting an email as well. It'll include both emails will include the link to the recording of this webinar. Emails to those who attended will include the link to the survey in case you don't get redirected as we exit, and then also the CEH request form if you'd like to earn CEHs or CEUs for this session. The form will be included, as well as the handouts for this presentation so you can review it at a later date. And then, yeah, I'll just put up our upcoming webinars here, and then my email is at the bottom and phone number. If you do have other questions about this presentation or about our programs, feel free to contact me at the information there. And it doesn't look like we have other questions at this point, so I just want to thank you again, Dee, for that really informative session, and for bringing all of your particular experience and expertise to the table as well. We really appreciate hearing from your personal experience in doing this work. So thank you again.
Well, thank you, and I just want to wish everybody a Merry Christmas.
Yes, yes, thank you. And I would like to extend the holiday greetings as well, and hope everyone is safe and healthy, and hope you join us again in January. And with that, I will go ahead and close out. Have a good day.